Thank you so much. Hi, everyone. I am Chau, Shevrin, and I co-lead the National Center for the Study of Asian American Health at NYU and also the New York City Community Engagement Alliance to end COVID-19 disparities. My presentation today will be focused on the impact of the pandemic on health inequities. Next, please. So as you may recall, in April 2020, New York City was at the epicenter of the pandemic in the United States and worldwide. Next. And at the height of the pandemic, zip code map of COVID-19 cases painted a clear picture of stark disparities. However, race ethnicity data by zip code was not available for COVID during the early phase of this pandemic. In fact, in May of 2020 in New York City, racial ethnic data were missing for 59% of cases, 23% of hospitalizations, 10% of deaths, and as of fall of 2021, 17% of vaccination data. But we do know that the neighborhoods hardest hit were socially disadvantaged and predominantly comprised of low-income racial and ethnic minority populations. They were also neighborhoods with high population density, household size, limited English proficiency, poverty, and other social determinants for health disparities. Next, please. And I just want to highlight the issue of data quality. Oops, let's get back to the slide. Yes. Oh, actually, no, please go back a few more. And the next. So I think there was one more slide, but that's okay. Missing data and data aggregation were major challenges to achieving health equity and had implications for COVID-19 related diagnostic disparities. So nearly 2 years later, as of January 5th, 2022, data on race and ethnicity were missing for 34% of cases, 15% of deaths, and almost a third of vaccinations for the first and second dose, as well as 11% for the booster vaccination. Next, the people that are probably making up this missing group are more likely to be among one of these racial ethnic minority groups: Alaska Native, American Indian, Asian American, Latinx, Native Hawaiian, and Pacific Islander. Next, data aggregation is also problematic for a number of communities. Next, including Asian Americans, Native Hawaiian, Pacific Islanders, but also for Caribbean and African Blacks, Middle Eastern North African, as well as Arab American communities, and non-US born whites. Next. So I'm going to give you an example of the impact of misclassification in data aggregation and how that may mask disparities. In New York City in early 2020, the health department data suggested that Asian Americans were least impacted by the pandemic. However, we knew from our community partners and anecdotal experiences that the pandemic, the COVID-19, was really impacting our communities in varied and tremendous ways, particularly among low-income populations. So the issue of data quality and misclassification is also highly relevant for South Asian communities, who are often classified as other. To assess the impact of misclassification, my colleagues, Drs. Nadi Islam and Stella Yee, worked with the New York City Health and Hospitals Corporation, which is the city's largest public hospital system. And they examined roughly 85,000 patients that had been tested for COVID between March and May of 2020. In their analysis, they applied surname matching and other innovative methods, and they were able to classify appropriately and also double the sample size of Asian Americans in that database. And they were able to characterize and disaggregate data for specific Asian American groups. And so you can see that they found that South Asians, which are in blue, had the highest rates of positivity and also the second highest rates in hospitalizations due to COVID. And Chinese Americans, which are in red, had among the highest mortality for all Asians and all racial and ethnic groups, disparities that were not observed when the data was aggregated. So really underscoring the need to share data disaggregation by ethnic group and to also use innovative approaches to reduce misclassification errors in order to really understand the nature and prevalence of COVID-19 disparities. Next. I'm going to switch gears and share some experiences and lessons learned from our NIH Seal Award and the implications for diagnostic disparities. So through the Seal Award, we have been able to mobilize community, academic, and health partners to establish a centralized, coordinated community engagement platform in New York City to support activities related to increasing trust in science, acceptance and uptake of COVID-19 vaccines, and engagement in related studies. Next. The Seal Award allows us to support community-centered and participatory approaches working with local community organizations, faith-based organizations, minority small businesses, food pantries, federally qualified health centers, to employ community health workers as trusted messengers, engaging diverse populations and disseminating those messages and information about COVID-19 prevention and vaccination. It also allows us to work closely with the test and trace programs and the health department to coordinate access to mobile vans and other events for neighborhood-based vaccination engagement in communities that are medically underserved. Next. And through the Seal Award, we were able to culturally and linguistically adapt COVID-19 prevention, risk mitigation, and vaccination information in multiple languages, more than 12 languages, through a co-creation process with our community partners, which effectively reached limited English proficient in many immigrant communities. Next. This boots on the ground engagement has been very successful in reaching diverse populations. So as you can see from the data among adults ages 18 and older, between June and December of 2021, vaccinations have significantly improved in New York City during that time. And we know that for the second dose, it's about 5 to 10% lower for each group. Next. This figure here illustrates all the cases from the beginning of the pandemic to December 29 of 2021. And as of December, we have surpassed where we were from April 2020. And in this current map of New York City communities impacted by COVID-19, we also see that similar neighborhoods have emerged with respect to high social determinants of health barriers. They are low income, disproportionately minority, and they have issues related to economic, food, and financial instability, as well as the ability to secure test kits and have good testing access. Next. But fortunately, what we know is that the vaccine has been very effective to preventing severe disease and mortality. It is still high compared to where we were at 2020, but below what we would have observed in the absence of these vaccines. However, there are clear implications when you think about the number of cases that had increased or surged during the last couple of months because of the new variants. And those have implications with respect to thinking about COVID-19 related disparities, including PASC. Next, please. So there's a number of lessons learned from our vaccine efforts that have implications for persistent inequities, as well as clinical trials and engagement. We know that racism and historical mistrust in science still persist. There are issues with respect to misinformation, misunderstanding about the science and information regarding the vaccine and the virus, as well as disinformation, intentional spread of false information to wreak havoc among different communities and make it much harder with respect to vaccine uptake. There are still many issues related to vaccine hesitancy, issues related to inconsistency of information from both federal and state sources. And so that impacts, from a community perspective, what can be perceived as trusted sources of health information. Other issues too that impact low income and limited English proficient communities are issues with respect to complicated scientific language barriers, the need for expertise in cultural and language adaptation to really reach these communities. There are issues with respect to lack of participant incentives, time constraints, concerns by the individuals regarding loss of time and money due to issues with respect to a positive COVID-19 diagnosis for financially unstable or unstable communities. And then there are also the issues with respect to immigration status. And as we near 2 years with respect to this pandemic, there's pandemic fatigue for many communities across the board. And in the last month and a half, we've seen issues with respect to access to testing, resources that including PCR tests for many communities. Next. So in terms of thinking about this, there are many lessons learned with respect to clinical trials engagement. I think this is really important. We know that racial and ethnic minority communities were historically underrepresented in clinical trials. And this leads to lack of generalizability and relevance of therapeutic and health strategies for many racial and ethnic minority populations. There are issues that we have to also contend with respect to mistrust of science and poor participation in research. But social determinants of health are major issues that still need to be addressed at many different levels, as noted by our earlier speaker, in terms of not only reducing and preventing disparities, but also thinking about engagement, recruitment, and retention in clinical trials. And as I mentioned before, misclassification and poor data quality is inherent in our current data systems, and that may also lead to unconscious biases of research teams and providers. And also poor understanding of the nature of that disease for certain populations. For example, the nature and context of that disease for Asian American populations, the complexity of scientific terminology that makes it difficult for individuals and communities to really understand risk-benefit of whether or not it's getting the vaccine or participating in a clinical trial, and the need for culturally and linguistically appropriate materials. The underrepresentation of minoritized communities really has implications on improving diagnostic tools and also thinking about diagnostic inequities. Next. I just want to shift gears just for a second in terms of reminding us about one key strategy with respect to reducing disparities related to COVID-19 and other health disparities is thinking about how do we sustain and strengthen our safety net systems. The past 2 years have really highlighted that vital role of the safety net systems in serving low-income, uninsured, racial and ethnic minority communities and communities that were hardest hit by the pandemic, as well as other chronic comorbidities. These same systems were financially strained before the pandemic and were incredibly besieged during the last 2 years. So as we're thinking about preventing diagnostic and therapeutic associated inequities, we also need to think about how do we sustain and strengthen these systems. We know that, for example, in New York City, the Health and Hospital Corporation provided a huge resource for many of these communities with respect to testing, but we also know that there was a need to really shore up frontline and healthcare worker, their infrastructure for that, strengthening their data systems, enabling them to be able to disaggregate the data, as well as enabling them to be able to rapidly respond to health issues and return diagnostic results in a timely manner. The other issue related to treatment equity is the issue of ensuring that there's state-of-the-art technology. Many of these safety net systems have been historically disinvested, and they may not have the capacity or the technology to support some of this innovative and cutting-edge treatment that is coming, that has emerged with respect for COVID-19. And that creates another situation, another gap in terms of really raising disparities in this area for vulnerable populations. The other thing I want to note about strengthening safety net systems is to think about payment reform to ensure their financial stability, to help incentivize those systems that are providing care to individuals with the highest social and health needs, and really providing them the resources to be able to sustain that capacity, as well as sustaining a community health worker workforce who can work and reach out to many of these communities who might experience language access issues or issues with respect to immigration-related concerns, and then bolstering pandemic response for these safety net systems, because we know that we're hoping that this pandemic will end in the next year, but there's a likelihood that other viruses or other issues with respect to climate change and disasters may surface in the next few years, and we have to think about the long-term strategy for these safety net systems. Next. So some of the recommendations I wanted to make with respect to what we have learned from our vaccine efforts and what we've seen in New York City is that, again, as our first speaker had noted, social determinants of health, not only in terms of engaging communities where they're at and addressing the needs that impact them, but thinking about prevention. Many of these communities had issues with respect to sheltering in place safely, isolating safely, particularly in densely populated neighborhoods and households. Food, housing, and income instability were issues that needed to be addressed to reduce their risk. In addition, place-based approaches, community-centered approaches need to be strengthened. We know that working with trusted messengers and trusted community structures like community-based organizations, faith-based organizations are key to really improving trust in science and engagement around the vaccine, as well as clinical trial studies. And some of the other issues are related to building community capacity, ensuring that there are enough resources with respect to masks, test kits, as well as testing access for low-income, racial and ethnic minority neighborhoods and communities, and ensuring that we can address some of the issues related to misinformation and disinformation, utilizing and strengthening community clinical linkages, namely working with community health workers, and also strengthening the capacity of small independent provider practices that often serve many of the limited English proficient immigrant minority populations, as well as federally qualified health systems, and thinking about how do we strengthen our safety net systems in order to reduce further disparities over the long term. And with that, I am done. Thank you so much.